Today we will review urethral injuries, focusing on anatomy, types, imaging findings, and the role of radiology in diagnosis and management of the urethral injuries. These injuries are though uncommon but are clinically significant due to potential complications like stricture, incontinence, and infection. We will recall anatomy of male urethra. The male urethra is divided into anterior and posterior parts. The posterior urethra consists of prostatic urethra and membranous urethra, while the anterior segment consists of bulbar and penile urethra. This division is clinically important because urethral injuries often occur at specific segments depending on the mechanism of injury. This picture is showing the schematic diagram of the urethra. As you can clearly see, starting from the fossa navicularis, first part is penile urethra, which is the longest part of the urethra, then followed by bulbar urethra, where ends and bends are present. And when ends and bends are terminated, then next part is the membranous urethra, which passes through the bony ring of the pelvis. Then the next segment is the prostatic urethra, and where prostate is present around that segment, and then there is bladder neck, and then urinary bladder is starting. Anatomy of female urethra. Female urethral injuries are less common due to the shorter length and protected location. However, they can occur with pelvic fractures, instrumentation, or childbirth trauma. As female urethra length is very short, it is 4 centimeter and most anterior to the vagina, it is less prone to the injury. And this picture is showing the external female genitalia. As you can clearly see the urethral orifice, location of urethral orifice. Etiology of urethral injuries. Urethral injuries may occur due to blunt trauma, particularly pelvic fractures affecting the posterior urethra, or straddle injuries affecting the anterior urethra. Iatrogenic injuries are common during catheterization or cystoscopy, and penetrating trauma can injure any segment of the urethra. Classifying urethral injuries into anterior and posterior is crucial because the mechanism, imaging, and management differs. Posterior injuries often follow pelvic fractures, while anterior injuries are frequently occurs due to straddle trauma. As this picture shows the division of anterior urethra and posterior urethra. Clinically, the classic sign is the presence of blood at the urethral meatus. Patient may be unable to void, and there may be suprapubic fullness due to urinary retention. Perineal hematoma may suggest anterior urethral injury, whereas a high riding prostate on digital rectal examination often indicates posterior urethral disruption. Imaging modalities include retrograde urethrophy, which is the gold standard investigation for evaluating urethral injuries. Voiding cystourethrogram is useful for posterior urethral injuries. Cross-sectional imaging may be indicated for associated pelvic injuries or when planning surgical repair. Technique of retrograde urethrophy. Retrograde urethrophy involves gentle catheterization of the distal urethra, followed by injection of contrast, and then image is taken. The radiologist looks for contrast leakage, length of urethral disruption, and any deviation from normal anatomy. As you can see, this is the image of retrograde urethrogram. Dye was injected after catheterization, and image was taken, and dye was passing through the entire length of the urethra and going into the urinary bladder. And this picture is showing the spillage of the contrast at the level of the post bulbar level. You can see contrast is spilling. Most probably there is any false passage or urethral injuries present. Imaging findings in anterior urethral injury. Anterior urethral injuries are commonly partial tears. On a retrograde urethrogram, contrast may extravasate locally. Associated hematomas in the perineum or scrotum are often present. These injuries may be managed with catheterization or delayed repair. While posterior urethral injuries often involve complete disruption at the membranous urethra, contrast may leak into the pelvis, and retrograde urethrogram often shows a gap between proximal and distal urethra. These injuries require careful evaluation due to associated pelvic fractures and potential vascular injury. Management depends on location and severity. Anterior injuries may be managed conservatively with catheterization for partial tears, whereas posterior injuries usually need initial suprapubic diversion followed by delayed reconstruction, or which is known as delayed urethroplasty. Complications of urethral injury include stricture formation, erectile dysfunction, incontinence, and infection. Early and accurate imaging helps us to guide proper management to minimize these risks. In summary, urethral injuries require prompt recognition. Retrograde urethroplasty is the gold standard. Management varies depending on injury site, and careful follow up is required to prevent long term complication. That's it from today's lecture. Hope to see you in upcoming lectures. Take care and goodbye till that time.